Should I stop sharing?
Are you ready to go?
Yes, I'm ready, sir.
You ready?
Yeah, I'm ready.
Actually, is after you. Good afternoon, everyone. Welcome to a session of Apollo Center of Excellence in Critical Care. And today, the topic that we'll be talking about is immediate care of a trauma patient. And to do talk would be Dr. Didipya Devaprasad, who is a consultant at the Apollo Cancer Unit in Tinampet, Chennai. Dr. Didipya, over to you.
Thank you. Good afternoon, everybody, and thanks to the Apollo Center for Excellence in Critical Care and Ravi Mahajan and this team for having me over to talk to you. Very elated to talk to you with Dr. Babu Abraham moderating the session. He is the first non-surgeon who is course director for the ATLS trauma, so and was my teacher and a senior colleague. So very happy to talk in a session where he's moderating, and Jude Thomas for coordinating the entire process. Without much ado, I'm going to talk to you about the immediate care of a trauma patient. Well, when you talk about care of a trauma patient, it could be the primary survey, the secondary survey, and even the tertiary survey. But here, because it's an immediate care of a trauma patient, I'm going to limit myself to the primary survey. You would have many approaches of dealing with such patients, but the approach that we are going to deal with today is the ATLS approach, the Advanced Trauma Life Support approach, which is an American-based approach. Of course, there are other approaches, but most of these approaches follow the same guiding principle. So when you talk about the ATLS approach of a patient of trauma, we go through the principle of A, B, C, D, and E. A, the acronym for airway, B for breathing, C for circulation, D for disability, and E for environment and exposure. Well, though all of us would know this, but what we fail to recognize that A is just not airway. A is airway with cervical spine stabilization. B is just not breathing. B is breathing with ventilation. C is just not circulation. It's circulation with hemorrhage control. When you talk about disability in D, it is not an orthopedic disability. It's not a bone disability. It's not a joint immobility, which is causing a disability that we are worried at. We are not looking at vascular disability. We are not looking at spinal cord injuries which are causing disability. We are talking about disabilities of the brain. So when we talk about disability and neurological disability, we primarily are talking about disabilities that are caused because the brain is involved. And then we talk about environment and exposure. So let's go through this acronym. The acronym is A, B, C, D, and E, and we're starting with A, and A is airway with cervical spine stabilization. Let's look at the airway. It's a good practice to start all patients on high flow oxygen at around 15 liters per minute. And then you look, listen, and feel. What do you look at and where do you look at? You look externally, you look at the face for facial-maxillary injuries. If it is a badly deformed face because of a facial-maxillary injury, obviously the airway is threatened and it is by definition possibly going to be a difficult airway. Look for mouth ulcerations, look for neck injuries. If the neck is visibly displaced or you have crepitus, then it's going to be a laryngeal bronchial injury, which is possibly causing a life-threatening injury. So you have to look externally at the face, maxilla, mouth, and neck. And you look internally inside the mouth for vomiting, blood clots, food debris, dirt, broken teeth, or tissue that are occluding the airway. You listen for noisy breathing of stridor, and when you feel for the air movement, and you also feel for subcutaneous air. So talking about it, you look, listen, and feel. You listen for snoring, stridor, gurgling, and noisy breathing, and you feel for position of trachea and subcutaneous air. A simple 1 minute or less guide to assess the airway is to talk to the patient. If the patient is talking to you, definitely the airway is patent. However, if the patient is not talking to you, it could be possible that the airway is not patent, or even if it is patent, there's no way for you to know. And therefore, if you don't have a patient who's talking to you, then you need to have a more detailed examination of the airway. In this patient, you will open the airway, and the opening of the airway would be with a chin lift or a jaw thrust maneuver. Here you can see that they're also doing the head tilt, which is exactly what you're not supposed to do. And when you do the jaw thrust, ensure that you only do the jaw thrust, you don't cause any movement of the spine. And that is because it's just not airway, it is airway with cervical spine. So when you're looking at the airway, assessing the airway at any point of time and every point of time, you also have to ensure that the cervical spine is immobilized, because this is a patient with trauma. Then you will suction, consider adjuncts, and try to see whether you need a definitive airway. Okay, let's talk about a typical patient who's not talking to you and he's got a noisy breathing. So what do? So you do a jaw thrust and chin lift maneuver, again stressing the fact that you're not going to do a head tilt in this particular patient. So if by the jaw thrust and the chin lift, the noisy breathing disappears, then we know that this particular patient's noisy breathing was because of a tongue that was falling back, which has now been rectified by the jaw thrust and chin lift, and therefore the noisy breathing has abated. However, if the noisy breathing is either persisting, then you may want to think whether there are any particles that are obstructing. You could either use a soft catheter or a yonker, but since we do not know the size of the debris, which could be large, it may be a good practice to use the yonker to prevent any clogging of your suction catheter. So suction with yonkers. Remember that not all things can be suctionable. Obviously, a broken tooth can't be suctioned, and therefore you have to appropriately use other techniques such as the use of Miguel's forceps to remove any broken teeth in these patients, and then see after all these maneuvers whether the noisy breathing has gone away. If the noisy breathing has gone away, then you know that by opening the airway, the patient has gotten better, and now you would let go your jaw thrust and chin lift. And then if the noisy breathing recurs, then you know that this is because of the tongue again falling back, and to constantly keep the airway open, you may need an airway device, which could be an nasopharyngeal airway or an oropharyngeal airway. Remember that when you're suspecting base of skull fractures, it is contraindicated. The use of nasopharyngeal airways is contraindicated, and you would prefer to use an oropharyngeal airway. And if a patient needs an oropharyngeal airway and tolerates an oropharyngeal airway, it is an indicator of the need for intubation. I'm not saying that as soon as you place an oral airway and the patient is tolerating it, immediately prepare for intubation. I'm not saying that. I'm just saying that it is an indicator for need for intubation. And after you examine this patient, you will move away from this patient only after you have intubated this patient. It may not be immediate, but it will be subsequent. Remember that at all points of time that this particular patient needs to be placed on a cervical collar, unless definitely not indicated. Just asking you of situations where you think the cervical collar will be not indicated. Maybe I'm just going to give you two, and maybe you could come up with many more. One situation would be when you know the mechanism of injury. Suppose this patient has got a gunshot injury and that is causing his trauma. Then we clearly know that this is not a mechanism where the cervical spine is involved. Or rather, let's think of a patient who's had a stab injury. Here again, you would not anticipate that he has a cervical spine involvement. So unless you are specifically convinced that you don't have a mechanism of injury that can cause a cervical spine involvement, apply a cervical collar. When not in cervical collar, you have to use the manual inline stabilization technique. So when will this patient not be in a cervical collar? When we stress that this patient needs to be on a cervical stabilization at all points of time when not indicated, that is when this particular patient needs a neck examination or an intubation. At these points of time, you obviously have to remove the cervical collar to facilitate the examination of the neck and intubation. At this point of time, when you are not on a cervical collar, you have to ensure that this particular patient continues to have a cervical stabilization by using the manual inline stabilization technique. And even when the patient is on cervical collar, it is a good practice and expected that you use a manual inline stabilization technique when you're log rolling this patient and you're transporting this particular patient for procedures or for further tests. And this is the manual inline stabilization technique. Here you find the manual inline stabilization technique being given from the head end of the patient. And this is the manual inline stabilization technique given from the foot end of the patient. As you said, you would assume cervical spine injury unless and until you have a reason not to presume that this particular patient has got a cervical spine injury, which means in most systems of multi-system trauma, when you have altered conscious levels and you have a blunt injury above the clavicle, you will assume that this particular patient has got a cervical spine injury and restrict the spinal movement. Again, stressing the fact, avoid excessive movement of the spine, never hyperextend, never hyperflexate, or rotate the head and neck. And at all points of time, ensure that you give a manual inline stabilization when not on a collar, and you would use immobilization devices, which could be a collar, or more sophisticated devices, which will also cause a triple immobilization. Okay, still looking at the airway. Let's presume that this particular patient, despite us placing the oropharyngeal airway, continues to still have a noisy breathing, which means this particular patient definitely needs an intubation. If you are an unskilled person, call immediately for help. And when you're calling for help, ensure that you at least have a good knowledge of the bag mask ventilation technique. So you will bag mask ventilate and call for help. If you're a skilled person, you would obviously attempt intubation using a manual inline stabilization. Even if you're a skilled person and you may be the best person, but if you have failed attempts, always call for help and activate the difficult airway management algorithm. And this may need the performance of a surgical invasive airway, like a surgical cricothyroidectomy, a cricothyroidotomy, or a emergency tracheostomy in these patients. Always anticipate a difficult airway. You could use the lemon mnemonic, where you look externally, evaluate using the 3-3-2 rule, look for the Mallampati score, look for features that are going to cause a difficult airway. And obviously, by definition, N, where there is a restricted neck mobility, which is the case in a patient with trauma, you would definitely have a difficult airway. So have a predefined DAM algorithm. You may want to use a gum elastic bougie or a video assisted airway management technique, intubating LMA, or a surgical access if you think you have a difficult airway. Well, this is the Committee of Trauma and Emergency Protocol for managing a difficult airway. I'm not going to go into these details because this will be beyond the scope of this particular talk, but suffice to say that if a patient has got a recognized difficult airway, but if the patient is oxygenating well and hemodynamically stable and cooperative, always attempt an awake intubation. However, if it's an unrecognized difficult airway, or the patient is uncooperative, or is hemodynamically unstable, or has got a life-threatening emergency, you would attempt an initial intubation. If this is unsuccessful, continue with your bag mask ventilation until you call for help. And if your help helps you in intubating the patient, then you have no problem. If not, then you may have to go in with an emergency invasive airway technique. I would refer you to this particular algorithm in trauma from the Kotak group. So we did now finish the first part of our ABCD. This is airway with cervical spine stabilization. That being done and dusted, now we could go for B. Remember, B is just not breathing, breathing with ventilation. So here you again have to continue our examination, and the examination would be examination of the neck and examination of the chest. Let's pause for a moment and understand that you've already examined the neck while you examine the airway. In airway, in the neck, you specifically looked for whether there was subcutaneous air or whether there was any tracheal injuries. Here again, in the neck, look for tracheal deviation, look for subcutaneous crepitus, and look for whether the jugular vein is distended. Jugular vein distension is very, very important for us to note, because if the jugular vein is distended in a context of trauma, you are either dealing with a tension pneumothorax or a pericardial tamponade, which are both life-threatening situations which have to be dealt with immediately. However, in a patient with trauma, there could be a situation where the patient has exsanguinated so very massively that despite a tension pneumothorax and a coexisting pericardial tamponade, still the jugular vein need not be always distended. So on the contrary, if the jugular vein is distended in the context of trauma, always ensure that the patient does not have a tension pneumothorax or a cardiac tamponade, which has to be dealt with importantly and emergently. Now, the reason why I'm talking about the neck is that when you come to breathing, you should have already examined the neck and look for all these aspects when you examine the airway. There's no point in examining the neck in the airway and again removing the collar and examining the neck for breathing. Ensure that all this information that you'll need to examine this particular patient while you're dealing with breathing has also been obtained while you're examining the patient's neck for the airway, which means your examination will be limited to the chest when you're dealing with these patients. And you will classically do the inspection, palpation, percussion, and auscultation. What do you inspect in the chest? Obviously, you are inspecting whether there are signs of obvious injury in the chest, like contusion or bruise. You're looking at whether both sides of the chest are moving, whether you have a flail chest, whether there's symmetry of expansion. Palpation, you're obviously looking for tenderness, crepitus, and percussion is very, very important. A normal percussion note means it's normal. A dull percussion note, as all of you will know, would indicate that there is hemothorax, and a hyperresonant percussion note suggests that the patient has got a pneumothorax. So if you have a hyperresonant percussion note and a tracheal deviation, then you know this patient has got a tension pneumothorax. If you have a hyperresonant note and a absent breath sounds and a tracheal deviation, you definitely know the patient has got a tension pneumothorax. Remember, the tension pneumothorax is a clinical diagnosis, and do not wait for a chest X-ray or even a EFAST on an ultrasound to make a diagnosis of tension pneumothorax. Tension pneumothorax has to be recognized clinically and dealt with clinically. Obviously, you also auscultate this particular patients, and an absence of breath sounds will indicate that this patient will have a hemothorax or a pneumothorax. We've already said that this particular patient should all receive supplemental oxygen. And remember that you have to expose the chest adequately, the front, the side of the chest, all adequately, because you would be missing some injuries, especially when they are very, very laterally and low down in the chest, like a stab that is almost in the posterior axillary line. Remember that during intubation and a vigorous bag valve ventilation, you could convert a simple pneumothorax into a tension pneumothorax, and that should always be at the back of our mind. Okay, while we're continuing with oxygen, you will encounter any of these four situations which have to be dealt with accordingly. Let's presume that this particular patient has got a tracheal that is in the midline. He's got a jugular vein distension, and he's got absent heart sounds or muffled heart sounds. Clearly, the diagnosis is pericardial tamponade, and therefore this particular patient will need a pericardiocentesis under ECG guidance with a pericardial catheter that is placed for a continuous drainage and a referral to a cardiac thoracic surgeon, because this particular patient would need a definitive repair because he's got a cardiac tamponade. However, suppose this patient has got decreased air entry both sides, central placed trachea, a normal percussion node. Maybe this particular patient has got contusion of lungs with traumatic areas. Maybe this patient would need only intubation. Let's say that this patient has got a collapsed jugular vein, maybe this patient has got a dull percussion note and absent breath sounds on the left hemithorax, then clearly this patient has got a left hemothorax, and this patient will need an ICD placement with underwater seal. However, if the patient has got a jugular venous distension, an absent breath sound on the left side, and a tracheal deviation to the right, clearly this particular patient has got signs of left tension pneumothorax, and therefore this particular patient will need an immediate needle decompression followed by an intercostal drainage connected to an underwater seal. Remember that we no longer place the needle for a needle decompression in the second interspace, we place it in the fifth interspace. And the intercostal drain will be in the fifth interspace as always. Always try to choose a size that is somewhere between 28 to 32, so that if you have a coexistent hemothorax, it doesn't get blocked. And remember to always connect it to an underwater seal. So we have dealt with A, that is airway with cervical spine stabilization, breathing with ventilation, and now we need to come to circulation. So how do you assess circulation in a patient? You assess the heart rate of the patient, the blood pressure of the patient, the peripheral pulses of the patient, see whether the peripherals are cold or not. Always look for a central capillary refill time. Don't look for the capillary refill time in the finger beds or in the nail beds, because that is a peripheral capillary refill time. You have to assess a central capillary refill time, which means you're going to assess the capillary refill time over the sternum. Anything more than 3 seconds implies that the circulation is deranged. Obviously, you'll also look at mental status changes, and after an hour, you'll also be continuing to monitor the urine output. The only two investigations that you may probably need would be a lactate and an hemoglobin. Obviously, a lactate that is elevated in a context of a trauma suggests that there is hypovolemia, hypoperfusion causing a lactic acidosis because of an anaerobic metabolism. Obviously, if the hemoglobin is dropped, we know that this particular patient is exsanguinating. So talking about it, remember that the earliest sign of shock in these patients will be postural tachycardia and postural hypotension, which may not be always easy to pick up, especially when you are trying to maintain a standard position for patients in trauma when they're lying down. Remember that when you have a supine hypotension in the context of trauma, that it has got a 96% specificity to detect a significant bed loss. So never, never, ever miss out a supine hypotension and ignore this patient. This patient has got a significant blood loss, which has to be addressed immediately. So when we are talking about shock, as we have recognized shock, you may have only one of those 4 causes of shock when you're dealing with these patients. You may have a hemorrhagic shock or an obstructive shock or a neurogenic shock or a septic shock. But in the context of an immediate trauma patient, septic shock is unlikely in the first 20, unless it is beyond 24 hours. So it could be neurogenic shock, but in a neurogenic shock, you expect to have warm peripheries and a relative bradycardia, and that doesn't really kill the patient. So we are worried about only hemorrhagic shock and obstructive shock. Let's pause for a moment. The only 2 causes of obstructive shock are tension pneumothorax and a cardiac tamponade. And where did we deal it? We dealt with already when we have examined a B. And therefore, when you have a structured approach of the A, B, C, D, so when you come to C, you've already ruled out an obstructive cause of shock. And therefore, if you have a patient who still remains to be in shock when you come to examine your C, it means this patient is in hemorrhagic shock, which is the commonest cause of shock in a patient with trauma. So when you have a hemorrhagic shock, you have 1 on the floor and 4 more, which means you could have bleeding on the floor, meaning to say that then you have to look for an external bleeding source, which could be packed, or a tamponade could be done by placing a compression bandage, or you'll have to look into one of the 4 cavities. The 4 cavities are the chest, the abdomen, the pelvis, or the long bones. So this would be the way in which you deal with patients with shock. We have to still look at grading of shock. You do have the grading of class as class 1, class 2, class 3, and class 4. In interest of time, and because I know my subsequent speaker would be dealing with in detail, I leave it to her. Once you've dealt with, you'll have to understand whether your particular patient is a responder or not. You classify them based on whether they're responders, partial responders, or non-responders. And while you're evaluating a patient with shock, after you've examined the pulse, blood pressure, the peripheries, you have to examine the abdomen, which means you have to open the abdomen fully, inspect, palpate, and percuss. And if you have areas of tenderness or visible contusion or bruise, then it may indicate that this particular patient may have a bleeding within the abdomen. You have to definitely use fast, and fast is a very useful adjunct, especially when you're dealing with evaluation of your circulation. As much as we're talking about fast, let's also look at where fast is misused. There are certain instances where fast need not be used at all. One such instance is when a patient has got an obvious penetrating injury in the abdomen and is in shock. This particular patient does not need a fast. This particular patient just needs to go to the OR because this particular patient has got a bleeding in the abdomen. So if this particular patient needs to move to the OR, please don't waste your time by doing your fast and actually take away time from the patient when he needs to be taken into theater. So who is a rapid responser? Anyone whose vital signs which are abnormal normalizes after a fluid transfusion, this patient is a rapid responser. The blood loss is expected to minimal, and you can wait for a fully cross-matched blood. If a patient responds but then deteriorates, then this indicates the patient has got a moderate and ongoing bleed. The requirements of fluid are high, and therefore you may not have to wait for a cross-matched blood. You can give them type-specific blood. If the patient is a non-responder, then there's a massive blood loss. Fluid requirements are going to be very high. Then you may have to have an emergency release of blood, and especially O negative blood. Some of these patients may be a good responder, and the fast may be negative, and therefore you may need additional tests to find out the source of where they're bleeding. In these situations, you may need a CT scan with an angiogram, maybe. In these patients, may need an intervention. What are the interventions? The patients will need a surgeon to deal with an intra-abdominal problem. The patient, if he has a pelvic problem, you may try to do a pelvic binder, or you may do a pelvic fixation, but still if there is bleeding, then you may need the support of an intervention radiologist to do the Rebola or other techniques to minimize bleeding in the pelvis. Or it may be an external bleed. The patient may be bleeding from a femur fracture, and all that you'll have to do is to traction and splint, and that is going to minimize the bleeding. So it really depends on where you have the bleeding on the floor and four more. What you're very worried is the lethal triad, which is the triad of acidosis, hypothermia, and coagulopathy. And how do we prevent this? Hypertension is hypovolemia until otherwise proven, and therefore we need to get in 2 large bore catheters and infuse blood. So what are the catheters that you need to get in? You need to get in an orange or a gray catheter, a 14 or 16 gauge. Anything below it is not acceptable. So you need to get a minimum 2 large bore catheters and give them IV fluids until blood is made available. Remember that you need to have blood, and blood can only replace blood. But until you get blood, it is okay to give IV fluids. You could give balanced salt solutions, normal saline or Ringer's lactate up to 1 liter to achieve appropriate response. And beyond that, it should be blood. And remember that when you give blood or fluids, it should be adequately warmed between 37 to 40 degrees centigrade, and always look for responsiveness. I understand that there could be certain situations where you don't have a blood bank and there may be a delay. In these situations, it may be okay to go beyond 1 liter of fluid to maintain hemodynamics, but as much as possible, stick to 1 liter and replace the remaining with blood. So to combat the lethal triad, we have the technique of permissive hypertension, hemostatic resuscitation. We need to treat the coagulopathy. Obviously, shock was circulation with hemorrhage control, which means you have to stop the bleeding either by involving the surgeon, either by placing a pelvic binder, or by using the services of an intervention radiologist or by just splinting. And permissive hypertension is to delay the fluid resuscitation until the hemorrhage is controlled, which means you're going to target a map of 65 or blood pressure of 80 to 100 until major bleeding is stopped. Remember that you do permissive hypertension only if a patient does not have significant brain injury. Here, you correct the hypovolemia after damage control surgery has been done until the lactates are normalized and the base excess is normalized. Until the surgical control as bleed is achieved, you could delay fluid resuscitation, especially in a penetrating torso injury. And this is permissive hypertension. What do you mean by hemostatic resuscitation? Understand that because the patient loses blood, which means he loses all components of blood, if you're going to replace it only with packed red cells, you have a dilational coagulopathy because you're not replacing them with platelets and with other coagulation factors. And therefore, it's a good practice that for every packed cell that you give them, you also give them 1 unit of plasma and 1 unit of platelet, and anticipate whether you need to activate the massive blood transfusion protocol. Now, what is the massive blood transfusion protocol? It is when you need large volumes of blood up to complete plasma volume in 24 hours. You could have other definitions as well. You could use any score like the ABC score, which is the assessment of blood component score, which is a simple tool which would tell you whether this particular patient needs massive blood transfusion. Here, talking about the score, if the patient has got a penetrating mechanism, blood pressure less than 90, heart rate more than 20, and a positive fast, then he has a score of 4, which means he needs massive blood transfusion. So this has got a 75% sensitivity for predicting massive blood transfusion. And this is possibly useful in centers to give a request to the blood bank, an advance notice to the blood bank that you are in need of a large amount of blood, because they also have to make arrangements for these bloods. We talked about treating coagulopathy. If you do the 1:1:1 protocol, we think we'll be minimizing the dilution coagulopathy, but it may not always be so. But to fine tune it, you may use point of care testing like the TEG and ROTEM. If you don't have these point of care testing devices, don't worry. You could still go in with your conventional tools, which is your prothrombin time, activated partial thromboplastin time, your fibrinogen levels, and your platelets, and tailor your needs appropriately. Or you could have a preset transfusion package, such as the one that is given to you. In this particular protocol that is followed in a hospital, they first give 6 units blood and plasma. And if the patient needs additional units of blood and the plasma, they give 1 platelet apheresis. So that's how it would. And with continued need, they also examine the need for giving cryo. So you can either give a 1:1 protocol, or you could use point of care testing to determine what the patient needs, or you can use PT, APT, or you would go with preset transfusion packages. Well, a word about tranexamic acid. Tranexamic acid, 1 gram given as a first dose within 3 hours of injury, followed by an additional dose given over 8 hours, has known to improve survival, and it will be a good practice to act. So staying on with circulation, it's important that you recognize that this particular patient is shock. You need to give 2 IV bore needles and give them blood as well as fluid about a liter until blood is made available. Identify the site of bleed. You may have to use fast, and sometimes you may have to use other sophisticated techniques. And remember that if it's an external bleed, you will have to give pressure or pack the wound or take a surgical stitch or even apply a tourniquet. If the patient has an abdominal source, then he may need a surgeon to do a damage control surgery. So the 4 areas of hemorrhage would be the chest, where you need a chest tube, an abdomen, where you may have a clinical examination, a fast, and a possible damage control surgery, pelvis, where an X-ray pelvis or a fast will be able to tell you where the source of bleeding is. Maybe the patient will need a pelvic binder. If that's not working, a fixator is not working, then you may need interventional radiology to help you. And if it's going to be the thigh, the patient will just need splinting after traction. Remember that the purpose of surgery is only to get bleeding control and decontaminate the body cavities. It is not a definitive repair. There is time for definite repair. You could do a definite repair later on. The aim of the procedure is to restore or optimize the physiology instead of a definite anatomical repair. So we are finished with A, we're finished with B, we're finished with C, which means we're coming to D, which is neurological disability. There are only three things that you'll assess in neurological disability, and that is the GCS, which is the eye motor response and the verbal response. You look for pupillary size and reaction in both ears and look for whether there is any focal neurological deficit in this patient. Based on the GCS, you classify the patient as having mild, moderate, or severe. GCS of 13 to 15 classifies as mild, 9 to 12 is moderate, 8 or less than 8 is severe. And once you're classified, you need to make three decisions. Either the patient needs an airway, the patient needs a CT, or whether the patient needs a neurosurgical consult. If a patient has got a severe head injury, no questions asked, he needs intubation, he needs a CT scan, he needs a neurosurgical consult. If a patient is in moderate, he may or may not need an airway. He'll definitely need a CT scan and definitely will need a neurosurgical consult. If a patient is in mild, unlikely this patient needs an airway for a neurological disability. He could need an airway protection for other reasons, but unlikely that he needs it for the head injury per se. He may or may not need CT brain, and he may need a neurosurgical consult. So let's look at those specific situations in mild head injury, mild GCS, where you don't want to do a CT scan. So if the patient has got a mild injury and the patient has got seizures, has got vomiting, has got amnesia, age is more than 65, he's got a dangerous mechanism of injury, or he's got a base of skull fracture like a raccoon eye, CS of autoria, CS of rhinorrhea, battle sign, then you would definitely need a CT scan. For all practical purposes, patient in most situations would need a CT scan. Remember that an expanding intracranial mass is the next cause of death, and therefore you should alert the neurosurgeon appropriately early enough to manage this. Remember that a loss of consciousness in trauma could be because this patient has got hypoxemia, which you've managed to correct in A, hypercarbia, which you've managed to correct in B, or hypoperfusion, which you've managed to correct in C. And therefore, because you've corrected all of this, when you examine this patient, you expect that you have an appropriate assessment of his neurological disability. Yet it may not be possible because the patient may be under the effect of drugs or under alcohol. It is also important to realize that we need to prevent secondary brain injuries. Most importantly, avoid hypotension, avoid hypoxemia, avoid hypercarbia. At the same time, don't try to attain hypocarbia. Obviously, avoid hyperthermia as well. Keep the glucose, keep the hemoglobin and the pH at appropriate ranges. And then we come to E, which is to prevent hypothermia, which again, we talked about how hypothermia contributes to lethal triad, and in exposure, you may have to log roll this particular patient. We've told you while we examine the neck, we examine the chest, we examine the abdomen, we examine the thigh, we said this patient has to be thoroughly examined, and that's possible only if the patient is completely undressed. But remember that as soon as the examination is done, please cover this patient back to avoid causing hypothermia and control the room temperature very strictly. Remember the patient's body temperature, that is more important, and not the comfort of the healthcare. Before I end, just a few misconceptions and sources of error. It is not necessary that the patient has to be intubated in A. Maybe the patient has got a tolerance of an oral airway, which means the patient has a need for intubation, but doesn't mean that this patient has to be intubated in A. Always come back, complete your examination, and then intubate this patient. Maybe this patient has got a tension pneumothorax. So if you're going to intubate in A, this tension pneumothorax will get worse with your bag mask ventilation, and the patient will arrest in front of you. So always don't really jump guns, go through this protocol. That's why this has been structured. Remember, when you're ventilating, don't overventilate to cause hypocarbia. As much as you need to use fast, don't misuse fast. And if you find that the patient has a bleeding, please give an early surgical referral, because remember, circulation is just not assessment of circulation is also hemorrhage control. So unless you call the surgeon who takes him for a damage control surgery, you don't do appropriate justice to C. In D, always we find that either the CT is delayed or the CT is done very, very much early. Even when you've not even assessed your circulation, people sometimes shift them for a CT brain, which is not necessary. I've seen instances or heard about instances where the patient has been shifted for a CT scan of the brain and arrested on the CT gantry, only then to realize that this patient has a missed splenic injury, which if addressed early would have prevented the unfortunate death of these patients. So rule of thumb in trauma resuscitation is that you appropriately use PPEs. It's not necessary that you make a definitive diagnosis, but never delay initiation of resuscitation. Treat the greatest stress to life. Detailed history is not necessary to begin your resuscitation, and always follow the ABCDE protocol. And that is a method to this protocol. And the rationale for it is that airway kills earlier than breathing. Your loss of airway kills quicker than your ability to breathe, loss of ability to breathe. Your loss of ability to breathe kills quicker than the loss of blood volume. And once you've appropriately restored A, B, and C, you could have a good assessment of your D. And remember, then if you find a problem in D, that is next most lethal problem. Trauma kills in a predicted fashion. Initial assessment and resuscitation has to be rapid. Life-threatening injuries have to be fixed as they are found. Systematic approach by sticking to the ABCD sequence has to be followed, and time is of essence. Thank you for your patient hearing.
Thank you, Dr. Deepya.
Thank you, sir.
I think if there are any questions, we will take it after we have listened to the next speaker, Anjali.
Yes, sir.
If you are ready, maybe we can do your talk and then we will go to the next question and answer.
Yes, sir, I'm sharing my slide.
Thank you.
Namaste, sir. Namaste, madam. Myself, Ms. Mitanjali Mahanti, in charge of Emergency Department, Apollo Hospital, Bhubaneswar. Renders the heartfelt thanks to our very own, loving, positive understanding, helping a mother figure, none other than the Captain, Dr. Usha Banerjee, for helping each and every nurses, motivating them to go for the excellency and spread their wings and keep flying and touch great heights. I feel proud that I got such a big scope today. Being a nurse, I am able to face such a huge gathering talk with them, share knowledge and discussing about certain complicated and newer cases. And most importantly, I could share my viewpoints and think an extra step towards the patient benefits. I am privileged enough to be a part of Apollo and headed by a great leader. It is indeed a beautiful journey where every single day I get scope to learn and spread the knowledge. As it is rightly said by our Usha ma'am, if you keep sharing our knowledge, it will be only help us to grow further and together. Thank you, ma'am, for creating a such great platform us when we can speak and be a part of it. Once again, thank you, ma'am. Moving to the next eminent personality, our moderator, sir, Dr. Babu Abraham, who is the Senior Consultant Pulmonary and Critical Care Medicine at Apollo Hospital, who has coordinated with me throughout and guided us to prepare the case. I am thankful, sir. Your guidance has really helped me to prepare this case so well, made it is easier for this and to maintain the clarity and understand with us. Thank you, sir. Thanking to the next speaker, Dr. Didipiya Devaprasad, who is the consultant and the head critical care unit, Apollo Cancer Institute, giving me opportunity to be a part of this discussion and I can share my viewpoints on this. Thank you, sir. Last but not least, Thanksgiving it is not complete if I am not thanking to our own nursing superintendent, Ms. Minati Panja, is a without her journey, it is incomplete. She is our pioneer, our driving force and motivational skill. Lastly, thanks to the team Bhubaneswar, who has been a part of my life in the case and key. Thanks to the clinical team and my emergency department, especially HOD emergency Dr. Priyabhat Sahu, who have said so well motivated to me. Thank you, ma'am, for giving this scope to me. Now we'll go for my presentation. That is the immediate care of the trauma patient. In India, every minute accident happens. Every 4 minutes, one person dies due to the road traffic injury. Deaths are mainly of the age group of 18 to 44 years. Overspeeding is the most common for the cause of RTA. Even after modernization of the hospital, death rate is still high. For this, the initial assessment is most important. The initial assessment and management of the trauma patient is challenging task, but requires rapid and systematic approach. Aim is to prevent early mortality rate. It occurs due to the failure of oxygen of vital organs and central nervous system or both. In initial assessment, we have some certain parameters like preparation, triaging, primary survey, ABCD approach, already discussed by the sir. Resuscitation, adjust to the primary survey and resuscitation, consider need for the patient transport. Secondary survey, that is includes head to toe evaluation and patient history. Adjust to the secondary survey and continued post-resuscitation monitoring and re-evaluation and definitive care. In the preparation phase, it is mainly divided into two types, pre-hospital phase and the hospital phase. In the pre-hospital phase, the paramedic or the nurses manage with the minimal resources in field. The more emphasis the paramedics manage with the minimal resources in field. Emphasis is given on the airway maintenance, control of external bleeding, immobilization of the spine, immediate transport to the closed trauma center, informing the receiving hospital. In the hospital phase, dedicated area for the trauma patient resuscitation, airway equipments are ready, warm pistolettes are ready, monitors and prompt lab and radiology services. Trauma team includes the emergency team, neurosurgery team, orthopedic team, surgery team, gastrointestinal surgery, critical care, thoracic surgery, and the vascular surgery. Trauma team activation. Whenever the trauma patient, the systolic blood pressure is less than 90 mmHg, and there is a requirement of endotracheal intubation, mechanically unstable pelvic injury, and the Glasgow scale is less than 14, amputation proximal to the ankle or the wrist, patient requires urgent surgical intervention. Then we go for the triaging system. The triaging sorting of a patient according to their need for the assessment. This is called the triaging. Here we are using the 4 color code, that is the red, yellow, green, and black. Here the black is the death, there is a no breathing, no pulse, then we categorize as a black. If the patient is walking and it is categorized as a priority 3 or patient 2 shifted to green zone. If the respiration rate is less than 12 or more than 22, then it is categorized as a red zone. If the heart rate is more than 100, then also it is categorized as a red zone. Glasgow scale less than 10, then it is categorized as a red. If there is a 10 to 14, then it is priority 2 or the yellow zone. This is our the triaging scale we are followed here. Then comes for the primary survey. In primary survey, we focus on the ABCD approach. A means airway maintenance with the spine protection, breathing and ventilation, circulation with the hemorrhagic control, disability, exposure, and environmental control. First one is the airway maintenance with the C-spine protection. Airway patency is first assessed for the patency. Signs of airway obstruction, inspection for foreign body, blood, gastric content, facial, mandibular or tracheal, laryngeal fractures. GCS less than 8 may require definitive airway. Head and neck to be immobilized manually by assistant during the intubation. Here we are also include the rapid assessment. The resuscitation, assessment, pain management and patient need, investigation, intervention, and the definitive treatment and disposition. In the assessment of the airway, completely airway obstruction may lead to the death within the few minutes. So partial airway obstruction can be recognized by the noisy breathing, such as snoring and gurgling sound. The level of consciousness decreased due to the reduced airway, muscular tone, loss of a protective airway reflexes, principally the gag reflex and the cough reflex, retention of a oropharyngeal secretion, and the tongue malposition. So level of consciousness we check by using the ABVU scale. A for the alert, B response to voice, P response to pain, U unresponsive. Patient is talking means the airway is safe. Simple maneuvers like head tilt chin lift or jaw thrust we are applied to prevent the partially obstructed airway and to correct the partially obstructed airway. The airway agents such as the oropharyngeal airway, nasopharyngeal airway can also be useful in this. Then comes for the breathing and ventilation part. Here be the examination of chest, that is the visual inspection, palpation, auscultation, and percussion. Ventilation requires adequate function of lung, chest wall, and diaphragm. Every trauma patient should receive the supplementary oxygen. Assessment of the breathing. Increased respiratory work commonly associated with the severity of illness. It leads to increase the metabolic rate and oxygen consumption. The leads to the respiratory distress, high respiratory rate, diaphoresis, and accessory muscle user, and it leads to the CNS. So we focused on the clinical examination, including the tracheal palpitation, percussion, and auscultation may pinpoint the some diagnosis. Tracheal deviation and hyporesistant chest indicate there may be a chances of tension pneumothorax. Dull percussion indicate pleural effusion or emphysema. Which or silent chest indicate acute asthma. Bronchial breath sound indicates the pneumonia. Then high flow oxygen should be administered in all acute ill patients. The effect of therapy should be assessed using the pulse oximetry, and the targeted oxygen saturation should be 94 to 98%. The approximately oxygen delivery device used by the high flow mask with the reservoir. It is vital that the reservoir is kept inflated at all times. This is usually achieved by setting the flow rate of oxygen 15 liters per minute. This mask will usually deliver an inspired oxygen concentration like 60 to 85%. The next one is the circulation with hemorrhagic control. Here the assessment is assessment of circulation. The assess the radial pulse, rate, rhythm, and character, and also blood pressure. Clinical signs that are common to hypovolemic, obstetric, and cardiogenic shock, including the confusion or agitation. Cold extremities reduce the capillary refill time, tachycardia, absent or small volume peripheral pulse, hypotension, or oligoria. The jugular vein pulse assessment is usually it is distinguished between the hypovolemic state low and the cardiogenic or obstetric shock. It is elevated. The circulatory features of septic shock include the one periphery, vasodilation, and the bounding pulse. Peripherally cannula can be usually inserted in the intercubital fossa or external jugular veins. And it is inserted by the two internal jugular vein and subclavian vein or femoral vein. Mainly, we are focused in the two large size 16 gauge bore cannula in intercubital fossa, and that is recommended for the fluid resuscitation. Sometimes the patient is not responding to the fluid resuscitation. That means there is some internal bleeding is there, mainly pelvic injury or long bone fracture, or there is abdominal injury. So, in circulation with the hemorrhagic control, the hemorrhagic shock is divided into 4 classes: class 1, class 2, class 3, and class 4. Here, the approximately blood loss in the class 1 is less than 15% of blood volume. That means the less than 715 ml of blood loss. In class 2, 15 to 30%, that means the 750 ml to 1500 ml of blood loss in the class 2. In class 3, 1500 ml to 2000 ml of blood loss, that is the totally 31 to 40% of blood volume. Then class 4, this is the severe, and there is a more than 2000 ml blood is lost, more than 40%. In class 1, the heart rate is normal. In class 2, may be normal, may be increased. In class 3, increased, but in class 4, definitely increased. Blood pressure also in class 1, that may be normal. Class 2 also normal, but in class 3, it may be decreased. But in class 4, it is decreased or non-decreased. In pulse pressure, class 1 and class 2, that is neutral, but in class 3 and class 4, 100% decreased. The respiration rate, it is normal in the class 1 and class 2, may be increased in the class 3, and it is increased in class 4. Urine output also normal in class 1 and class 2, but it is decreased in the class 3 and class 4. Then the need for the blood products, it is there in class 1, it may be continuous monitoring required. If required, we are provide the 1 crystalloid. In class 2, we may be possible to requirement of the blood products. In class 3, there is a chance of blood transfusion, but in class 4, we are 100% do the massive transfusion protocol. In massive transfusion protocol, rapid administration of large amount of blood products, at least 6 units in PRBC in fixed ratio, usually 1:1:1 for the management of hemorrhagic shock. PRBC fresh frozen plasma, and platelets. These are the circulation with the hemorrhagic cluster. Then next we go for the disability or neurological evolution. Here we have checked the GCS of the patient, level of consciousness, and pupil size. It reacts to the light or not on lateralizing sides. Then last one is the exposure and environmental control. Here we address the patient and what we focus on the how to prevent the hypothermia. Cloth may be need to be cut off, but after examination, also to the prevention of heat loss, we provide the warm blanket to the patient. Then next adjuncts are the Ecg monitoring. Dysarrhythmia may be suggestive of blunt cardiac injury, urinary captation, sensitive indicators of patient volume status, and reflects adequate perfusion. Gastric catheter reduce the stomach distension and decrease the risk of aspiration. Then ABG may suggest hypoperfusion and impending respiratory failure, especially in pregnant patients. Pulse oximetry measure the oxygen saturation of hemoglobin. Blood pressure, poor measures of actual status of perfusion. X-ray, chest and pelvic. E-FAST scan is also important in this. Then diagnostic procedures. In diagnostic procedure, we focus on the chest X-ray, pelvic X-ray, and C-spine X-ray. The FAST scan, the focus assessment with the sonography for the trauma, or the extended focus assessment for the sonography for trauma. These are the important for us. Then we go for the secondary survey. In secondary survey, we include the head-to-toe examination with ample history. Secondary survey is essential to head-to-toe examination with the completion of history and the reassessment of progress in vital signs. Then history. In history, we go for the ample. A, allergies. M, medication currently used. P, past illness or pregnancy. L, this was the last meal. E, events or environmental related to injury. A range of further diagnostic tasks and procedure may require after the secondary survey. This includes the CT scan, ultrasound, bronchoscopy, contrast X-ray, angiography, esophageal ultrasound. This may be required. Then second one is the definitive care. Definitive care, choosing where care should be continue most appropriately will be depend on the result of the primary and secondary survey and knowledge of the facility available to receive the patient. The closest appropriate facility should be chosen. The records and regard documentation. Here the nurses should be everything they are done that will be accurately maintained in the medical record. This is the important in trauma case. Then the case presentation. In our hospital, 37-year-old male presented to emergency department with the alleged history of road traffic history when the patient was not wearing the seat belt on a four-wheeler had hurt on the collision with the lawn. Initially treated at government primary care center, then was referred to the high center. The treatment received in the government hospital: injection tetanus toxoid, injection tramadol, IV fluid shifted to RL infusion. Then, whenever the patient came to Apollo Emergency Bhubaneswar, patient was twice read by the attending doctor and was wheeled into the resuscitation bay. In primary survey, ABCD approach, the airway, the patent and neck was immobilized with the collar, breathing, spontaneous but was tachypneic, connected to the nasal cannula, 2 liters per minute. Chest rise was equal and bilateral. Trachea was in the midline. Bilateral ANT was equal and there was no added sound. In circulation pair, IV assess done in the left forearm with the 18-gauge cannula. Initial the vitals are SpO2 100% on the room A, pain score 6/12. Here we are using the behavioral pain score. The capillary refill time 3 seconds. Disability GCS ET V4 M5. Pupil bilateral 3 mm and normal rate to the right. Exposure. Laceration over posterior aspect of the elbow joint. Deformity over the mid-shaft right forearm. Deformity and swelling over thigh, swelling and deformity over the knee joint. No injury seen in the avasta, hair around orbits, inside and around the oral cavity, perineum. Chest rise was equally bilateral, trachea was midline, bilateral anterior was equal and there was no added sound. Abdomen, soft, balsam present. In the FAST scan, there is no free fluid in the abdomen. Whenever we do the upper extremity examination, painful and restriction of movement around right elbow joint. Brachial and radial pulses present. X-ray of forearm including humerus, hand with the wrist and advice, and there is a fracture. The lacerated wound was irrigated and cleaned and wrapped in a bandage. Then whenever we do the head-to-toe examination in lower extremity, painful and restriction of movement of hip and knee joint, femoral falls present, popliteal and other distal falls, posterior tibia and dorsal pedis are absent. So immediately we are called to the vascular surgeon and immediately involve the orthopedic surgeon. CT angio of left lower limb was advised, which revealed non-visualization of left occipitator artery associated with the thrombosis due to the compression of tibial fracture segmentation. Then in 23rd March, external fixation femur and tibia done. 23 March, vascular tube grafting and envelopectomy. In the 30 March, complexion reconstruction of fracture. Proximal ulnar and radius reconstruction done on the first day. Then after that, after 15 days, the patient was discharged from the hospital. Timely intervention and completion of both primary and secondary survey save a limb in outer session. Here the secondary examination is most important. During the secondary examination, we save the limb of the patient. Then role of a trauma nurse. The triage patient or work with the triage nurses to help focus on the most critical patient first. They are first triaging the patient who are required red zone or yellow zone or green zone. Then recognize the signs of deterioration in unstable patients. Sometimes the yellow zone patients are deteriorated and consented to the red zone. Give first aid, CPR or other emergency medical care as soon as possible. Give emergency medications, give IV fluids, blood as per the physician advice. Perform the wound care. Work directly with the physicians to give the updates on the medical condition, wounds, injuries. Work with the patient and their families to give the reassurance and the explanation. Provide resources to the patient who have gone through a traumatic injury or event. Report the cases of abuse or neglecting to protective service organization. Work with a law enforcement if criminal activity is involved. Maintain a proper documentation of the care of the patient. Work calmly and carefully while dealing with the life-threatening injury. Make quick decisions to be able to help the patient. Juggle many different tasks and case at home. Follow instruction carefully during the treatment. So we are as a trauma nurse, we are mainly focused in the ABCD approach and secondary surgery. Thanks, sir. Thank you, sir.
Thank you very much. If there are any questions, both Dr. Didipia and Smitanjali would be happy to take questions.
There are no questions as such. So this is Ravi Mahajan. No questions as such, but just wanted to say thank you to Dr. Didipia as well as Shmitanjali for excellent presentation. And also thank you, Babu Abraham, for conducting it. It's been really valuable. At one stage, we had around 170 people watching it. So definitely the message is spreading around, which is great to know. Thank you very much. But if there are any questions, please let us know. If not, then I've got one or two announcements to make from the Apollo Center of Excellence in Critical Care. Can I go ahead, Babu?
Please go ahead, Dr. Mahajan. Yep.
Thank you. So it's for the critical care community of Apollo Network that I have 2 or 3 pieces of information. One is that the standardized mortality rate and its measurement, as you know, is going to become a norm within Apollo Network, and that's because this is also going to become one of the NABH requirements. So you'll be pleased to know that 7 or 8 of your units have participated in a pilot. Chennai have been doing it for a long time, and they were quite instrumental in running that pilot and letting us know how to do it. We have learned lessons from that pilot. and we will be sharing those lessons very, very soon with your unit heads. But this is just to forewarn you that this is going to become a routine practice in all the units in Apollo network. So just a piece of information there, but we are taking it very, very carefully, learning from the pilots, learning from each other, and making sure that we do it consistently and we do it properly. A second piece of information is with regards to the protocols and SOPs. As you know, many of you have contributed to the development of a manual of ICU protocols and standard operating procedures. One of those protocols on acute asthma was sent to you as part of experiment and learn from you in the form of an audit as to whether or not this will be a useful exercise. Your replies have come back and all of you have said that your units will benefit from protocol-driven care and that protocols of such nature would be of help. Many of you already have protocols running and many of you don't. So in some ways, having a standardized protocol will standardize the care across Apollo network. So in next few weeks, we will start sharing more protocols and more SOPs Apollo-wide for you to see how you can benefit from it. So that's the second piece of information. And third and final piece of information is with regards to enhanced connected care. We are embarking on a very ambitious project of monitoring the patients who are in the wards, not in critical care and not in high dependency units, but in the wards, but are deemed to be at risk of deterioration. So they will be monitored regularly or continuously, and there will be a system within each hospital of dealing with the detection of any abnormality in the monitoring system, and also treating if there is a treatable cause early. So early detection and early treatment of vulnerable patients who are at risk of deteriorating in the wards. That is the purpose of this project. We will be starting pilot from 1st of June in Chennai and Hyderabad, and very soon move to Delhi. And then learning from that pilot, within next 5 or 6 months, we will implement that in all different Apollo hospitals. As I said, an ambitious project, a lot to learn, and a lot is being learned, but I'm sure together we can make it. So I thought I'd just pre-warn you that this is coming your way, and I'm looking for all your support and all your help and all your camaraderie to take such good steps forward. Thank you very much for listening to me. Thank you. And thank you, Babu Abraham, for giving me that time. Thank you.
Thank you. So if there are no questions, shall we say this is the end of the session? And I don't think there are any more questions. Everyone is saying thank you. Okay, so thank you, everyone. I'm logging off, and thank you, Dr. Didipya, and thank you, Shalmale. Thank you very much. And Didipya, anything more you wanted to add?
Nothing, sir. Nothing. Yeah. I think whatever we had to say has been said. And thank you, Dr. Ravi Mahajan, and for this opportunity. It's great working with your team. And thank Smritanjali Mohanty for complimenting very much with the nursing aspect as well. Thank you. Thank you all.
Thank you, Smritanjali.
Thank you, sir. Thank you.
Thank you.